Yeah, 15th.
We'll do it.
And we could be there early, afternoonish.
Okay, excellent.
Yeah, maybe even, whatever earlier than that.
Okay, we'll chat. Yep.
Yep, good deal.
Santiago Brand.
Hello. How are you guys doing?
Good.
Good evening.
Good evening.
Yeah.
Good morning to you.
We were just talking, and Jay Gunkelman suggested to have you come on. We try to do our homework, and the best we could figure out is you're in Singapore. So we're going to need to be educated about you, Santiago.
Great. Yeah. So what would you like to know?
Oh, nothing. We're going to ask you about it. Just normally we do a little research on our guests, and we trust in Jay, and you seem to be all over the world. So you've been doing this a while. So we can't wait. We can't wait to find out more.
I'm thrilled to be here.
Okay.
Yeah. Thanks for coming on.
Oh, no, thanks for having me.
So the hardest part for you is going to be the intro. It's a tongue twister. However you want to introduce yourself. I just copied your LinkedIn information, and
great.
You can correct me. Hi, this is Santiago Brand. How do you even pronounce your last name?
Brand, I guess. Yeah.
Brand. Okay.
Yeah.
All right. And you're listening to the NeuroNoodle Network podcast that gets everybody. So
I know.
we'll record it, and then I will go back in and fix whatever. If there's something on the show that you don't like, we'll just pause, let me know, and I'll cut it out. Sound good?
Sound good.
All right, guys. Before we have Santiago do the intro, does anybody have anything else? Nope. Okay.
I don't think so.
All right. First check, is the show recording? Yes, it is. Okay. Second step, Santiago, do your intro.
All right. Hello, everyone. This is Santiago Brand, and I am the Clinical Director of MindLab Neuroplasticity Services, Vice President of SciTech Bioscience, and you're listening to the NeuroNoodle Network podcast.
Whoa.
First take, eh?
Oh, one take, Santiago. Love it. All right. This will be a quick show now. All right.
Great.
All right. I'm going to do my intro, and then I'm going to say Jay Gunkelman suggests you to come on, and then I'm going to say, hey, how do you know Jay? Right. And we'll get into it. We have one listener question on bipolar, and we can answer it to the best of our ability, and then if not, we'll move on. Okay, we ready, guys?
Yeah.
Hot tea, me. Thank you all for joining NeuroNoodle's Neurofeedback and Neuropsychology podcast, featuring our neuropsychologists, Dr. Laura Jansons and Dr. Skip Hrin. They've been practicing for over 50 years and are happy to share their knowledge with you. You can find Dr. Laura at Jansons.com, that's JANSONS.com, and Dr. Skip can be found at drskiphrin.com, that's drskip,HRIN.com. Please give us 5 stars on Apple Podcasts. It really helps get the word out on neurofeedback. The more that hear about us, the more we can help. My name is Pete, and today we're going to chat with Santiago Brand. Santiago Brand. Jay Gunkelman, QEEG extraordinaire, was on the show a few episodes back, and he suggested that we bring Santiago Brand on the show. Santiago, thanks for joining us all the way from Singapore, right?
That is correct, all the way from Singapore. Happy to be here. Thanks for having me.
Oh, man, thank you for coming on. It's 13 hours difference, so it's 9 o'clock over there?
That's right.
That's right. Okay, got it. So Santiago, how do you know Jay Gunkelman?
Well, I met Jay, I would say about 10 years ago at a restaurant in Sausalito, California, just on the other side of San Francisco, across the Golden Gate Bridge. And at the time, I was somewhat new to the field, and I was friends with Cynthia Kirsten. I was very interested in teaching neurofeedback to others, and I met with Cynthia So we had the idea of producing a workshop in Spanish, and she actually brought Jay along for the launch meeting, and that's when I first Jay for the first time. I met him for the first time, and after that, the relationship evolved in that I was more involved at one time, being part of the faculty for Brain Science International, and getting the chance to speak more with Jay during the meetings and some workshops. And I think of Jay more than a mentor. I think of him as a sensei, and I like to call him my sensei. If you think of that relationship in the Karate Kid between Mr. Miyagi and Daniel LaRusso, where he learns about karate and he learns about life. That's how I feel about Jay. I've learned a ton about the EEG with him, but I have also learned some really valuable life lessons from him. And he's one of the friends I love the most. I'm very honored to know him and work with him.
Next time we bring Jay on the show, we're going to call him Mr. Miyagi. So, Santiago, how'd you get started in neurofeedback, biofeedback, et cetera?
Well, I was doing my graduate studies in sports psychology. I'm a clinical sports psychologist. And as part of the curriculum for sports psychology, we had a biofeedback and neurofeedback class. And at the time, I remember thinking I was looking for something different to do with the athletes, something that would show more concrete and objective results when it came to brain training and enhancing performance. And it was by happenstance that it coincided that we had that class. And to me, it was love at first sight. And right there and then, this was back in 2002, 2003, I knew that this is what I wanted to do for the rest of my life. And I was at the time working with the Olympic Committee in Colombia. I quit my job. I flew to the United States. I did my first training in 2008 with Stens Corporation in Florida. I met a lady by the name of Dr. Susan Crum, who has a clinic there. I worked with her for 2 years. Then I quit, came back to Colombia, started my own company, and I've been doing that ever since. So it's been 13 years now.
Got it. And tell us about is it Minerva? Minerva.
Oh, well, I'm no longer involved with them.
Okay, all right. Yeah. Where are you at now?
Well, I am in Singapore. I just got here 2 months ago. My wife has a job here, and I am going to partner up with a colleague of mine. Her name is Sylvia Weatherall. She's from Portugal. And we're going to start a company called Mind Lab Neuroplasticity Services. So we're going to do neurofeedback, QEEG brain mapping, neurostimulation for corporate type clients, peak performance, and the like. So we're really excited about that.
Oh, nice. Outstanding. Congratulations.
Thank you.
Max, before we get to everything else, we have a listener question here I'd like to knock out of the way, and then we can get going with a conversation with Santiago. Do you find neurotherapy works or neurofeedback therapy works for individuals with bipolar disorder? Helpful, mixed, any feedback or any help would be appreciated.
Well, I think that it might potentially be helpful, but I don't think that bipolar is one of those conditions that you can target with neurofeedback alone. I'm always a big proponent of holistic and integrative interventions. And in fact, in my line of work, even if it is not directly, when I do neurofeedback or biofeedback, I always like to combine it with interventions like nutritional assessments and functional medicine and exercise. So, for the listener, if they're concerned about their bipolar condition, I would say try neurofeedback. I think can be potentially helpful, but you also need to take the pharmacological approach. You need your medication, you need good psychotherapy for it, you need good psychiatric care. You definitely need to exercise, you need to explore your dietary patterns and habits, and involving some sort of medicine practitioner like functional medicine or somebody with an advanced degree would be quite helpful.
Dr. Laura, Dr. Skip, anything with the efficacy of bipolar disorder and neurofeedback?
I'm going to defer to Laura.
Okay, and I was going to defer to Skip. Now, actually, I'm going to defer to Len Koziel. I loved his comments about Len Koziel, by the way. Santiago is me and our mentor from
Sensei.
our sensei, from a few years ago. We studied neuropsych together under Dr. Koziel, but he always had this great question every time we started talking about bipolar disorder. And his question always was to think about the last bipolar client that you had, and did they truly fit the classic bipolar, like how many bipolar people diagnosed with bipolar do we see in a true classic DSM sense? And so when I think about that, I think of, okay, the diagnostic manual that we follow for insurance purposes, I guess, talks about, these significant episodes of depression. And I think we see many classic depressed people in our practices, helpless, hopeless, feeling that, they can't go on and they have no efficacy sense, the low mood. We see that pretty frequently. But the question Len always asks is, do you see the classic manic symptoms? Do you see people frequently who are, out way overspending, buying, sailboats when they can't afford it, or are they, true bipolar? And so I'm going to ask both Skip and Santiago what Len always asks. Do you guys see this classic manic patient in your office, and how frequently do you see them?
I'll jump in, Santiago, if you don't mind. We do occasionally, given, just to contextualize, given our referral sources, one of our bigger referral sources is a community-based mental health clinic. And so they get to see all kinds of folks at varying levels of functioning. And so, like you're saying, the traditional bipolar, when it gets into the manic state, that's pretty disruptive behaviors. And I joke, but it's not a joke. When folks are in a manic episode, it usually ends in one of two ways. They get arrested or they go to the hospital. Like, you're doing things in your life that just don't work, and somebody's going to call the cops. It usually ends up that way. And so when we do see folks in our office that are, true, air quotes, right? Shout out to Tony, that they're being medicated, but they do have the symptoms and they have the history. When I was in private practice doing clinical work, hardly ever.
Right.
And for other reasons, right? And not to, pejoritize anybody, but usually folks that are going through bipolar aren't in a position to go meet their therapist once a week and talk about it, right? So since we're doing more assessment and evaluation these days, we do see more.
Yeah. Do you see a lot of that, Santiago, bipolar disorder?
Not really. I was just going to say the same as Skip, hardly ever, if ever, not even when we look at EEGs with Jay, that it would meet the classical definition, as you said before.
Yeah. And the point of Len's question, if I get it, is that bipolar is such a DSM specific diagnosis that it is difficult to define in terms of neuroanatomy. Or, what I see, parents will come in and say, I think my kid has bipolar. He's having these meltdowns. And so, again, what Len's point, I think, is that the meltdowns that children are experiencing, is that classic bipolar, or is it a cerebellum dysregulation? They can't regulate, they're overexpressing, overshooting, this dysmetria of their dysmetric emotion, so that their cerebellum is dysfunctioning. And so, the DSM doesn't really spell out, doesn't really map the neuroanatomy. And so that was kind of his point, is like, okay, what is bipolar anyway? Is it, this kid who's having a cerebellum dysfunction? Possibly, but he was kind of saying that there are two different things. Then I'll see some patients who, will come in and say, well, I think I have bipolar because my moods are all over the place. That 1 minute I'm fine and happy-go-lucky, next minute I'm bouncing off the walls. And so that bouncing off the walls, what exactly is that in terms of neuroanatomy or in terms of neuropsychology? Is it, behavior dysregulation from the cerebellum standpoint again, or is it, from the behavior gating systems involving the basal ganglia? Is it that kind of stuff? Is it frontal stuff that, they can't, there's no braking system. And so, it's really kind of hard to pinpoint what the DSM is going after, because it could be anything, anything anatomically. And I think that was Len's point, is like, what is bipolar anyway? And, is it, amygdala, issues? Is it front, and it's hard to define, and therefore, again, quote, what is it? And how many people do we truly see in the classic sense? And, substance abuse, lack of sleep. I mean, there's so many things. And so to the person's, question, what exactly, we need more of an assessment to understand the individual. I don't know if we can do a one size fits all, yes or no, what we're doing can affect bipolar. That's one thought that I'm having. And the second thought I'm having is, kind of back to, a lot of our discussions we've had here, that we're not, with neurofeedback, and you can give us your opinion, Santiago, in a sec, with neurofeedback, are we treating diagnoses, or are we treating brain dysregulation? Are we trying to adjust rhythm? And does the brain rhythm, have a flag on it that says bipolar? So we always kind of twist the question back to the patient, or whatever, just twist the response and say, we're going to try to get your brain healthier, put it in a better state, and then you'll be able to manage life better. When your brain's health, kind of like you said, Santiago, get exercise and body health and brain health, and then all of your symptoms of whatever type are going to improve. So I'm going to throw all of that back on you, Santiago. How often do you kind of mix the DSM and discussions of neurofeedback, or kind of what's your, I don't know, kind of response to all this stuff I'm bringing up?
Well, yeah, my approach is somewhat similar to yours. And every time I get the chance to go and deliver a workshop, the first thing I say is, what's in a name? And the way I approach the diagnosis, quote unquote, is I talk about patterns. I think we give names to things just because the client needs a name to something to make sense of it. But in reality, I'm very much against labeling or giving specific diagnosis, specific words to talk about something. So what I do is I talk to the client and I say, your brain wave patterns, the way your brain is behaving right now, what your brain is doing right now, it's that it's causing you to have a pattern or a tendency to gravitate towards a certain behavior or a certain thinking pattern that is not too healthy for you. Now, with neurofeedback, what we're going to do is we're going to optimize your brain functioning so that we can take you in a different direction, which is more adaptive. It's healthier for you in your interactions with the environment and everything else, right? So I always tell the clients, I'm not going to give you specific work. I'm not going to say you're depressive. I'm not going to say you're anxious. I'm not going to say you're bipolar. What I'm going to tell you is that you have a pattern. We can train that pattern and we can make it better for you. So, I think the same approach as State takes is talking about the neuronal substrates or whatever the person is presenting with, and staying away from specific labels, because I really don't like that. And I think it serves the client better. To me, giving the client a diagnosis is like giving an actor a character. They're going to own it. And they're going to be in character. It's like you have a method actor. They're going to be in character all the time. So if you tell them you're depressed or you're depressive or you're anxious, they're going to own it and they're going to act like it because that's what's expected of them. If you tell them this can be optimized, this can be changed, this can be made better, I think it provides the client with more flexibility to have enough motivation for us to do our work more properly. That's how I approach it generally.
Santiago, on that note, just out of curiosity, often discuss, or at least, comes around. So we comment on the impact and effects of the DSM. Our, framework of that is practicing in the United States, right? So just, on that note, can you comment on the influence of the DSM outside of the United States? What's it like in South America? What's it like in Singapore? Is it as heavy-handed and prevalent as it is here?
Well, I've only been in Singapore for 2 months, so I cannot really answer the question for here. But I'm going to say in South America, it weighs heavily as well. It's probably the equivalent to the Bible for psychologists. It's the book you go to for answers or references. I think that slowly but steadily, EEG work and the endophenotype model is gaining some momentum. It's a long way still. But I see more and more people staying away from just using the DSM and embracing other forms of intervention and assessment as well. However, it's still used very widely.
Yeah. And I had a comment, folks that have been listening for a while know about this. You don't yet, Santiago, but Pete's not a psychologist. And so he's always marveling at our answers and how they don't take 3 seconds. And so, right, the listener question is, hey, does this stuff work for bipolar? And we have to stop and say, hey, what do you mean by bipolar? And well, what does that look like? And so every question has 20 questions. And so anyway, Pete, at least there's some rationale behind it. It's not just, me and Laura.
Right. Yeah. So the maybe shorter answer is, a combination of what Santiago and Skip said, that you need further assessment, make sure you have the right diagnosis for sure. And medications are your best help to keep you out of jail, kind of stuff. But if there's brain dysregulation, or there's a pattern that's not healthy, the neurofeedback can be a supplement to what you're already getting. Is that fair?
I think it's fair. And I think also it's worth repeating that within the world of neurofeedback, it's not DSM driven. And certainly we recognize what that is and generally what folks are referring to when they mention a diagnosis out of it. But it's more about, all right, let's go from symptoms, right? What are we talking about? What do you experience? And so there you go, right? When you're working in neurofeedback, as Santiago just explained, it's more about let's look at brainwave frequencies and are they working in coherence and are things as they should be, or is something out of timing, right? It's just a really different perspective to start from. And so there's that too, right? It's a different look.
Well, docs, we're in an on-demand world, unfortunately, and the people are coming in, they only know one way to communicate with you.
Yep.
The EEG, that's another way that the client can communicate with you to tell you what's going on. If you're depressed, you have dysregulation in the front left. If you're anxious, it's the front and right. What's going on, whatever the definition of bipolar is, what do you think you would see on the EEG? Is it the sensory motor strip? I know you're going to say it's a combination of these things, but what's going to make you see something in a scan that says, we got something to take a look at here. This could be a bipolar situation, or you don't?
I'll jump. Could be anything, that's my whatever answer, but I'll try. Frontal lobe, you're going to have orbital frontal cortex, trouble regulating your speech, trouble regulating your behavior, and that's going to be a frontal issue. So not just regulating and controlling, but also what we were talking about probably last episode about motivation and drive. So your drive is definitely in the central frontal lobe. And so you're going to see possibly some issues there. And again, the patient's, I'd want to see what the patient's map looks like. And then that's going to help us, so if I'm wrong about that theory, that supposition that, it's probably frontal lobe, because that's where mood and drive are looped into. Or is it what I was saying earlier about, it could be a cerebellum issue, look into the back there. Or is it amygdala issue, look into the temporal lobes in the deeper subcortical level. So, I'd start in the front, and that's my guess, but I'd be curious with my guess versus what the map says, and that'll help, help a little bit with the diagnosis, and then help point the training, like lead the treatment plan, knowing what the map says.
What about ACC?
Yeah, exactly. Yeah, ACC. Yeah, so the
more frontal than not, right? Of course, but okay.
Yeah, I would say orbital frontal is all kind of wrapped into the anterior cingulate, and so it's gating your attention and gating your behavior and gating your thinking, and it's drive and push and stamina, and there's Dr. Tony talked about the drunken bull and the raging bull, so it's going to be the raging bull profile, so the opposite of mania is what? Depression, right? Kind of under functioning, and so it's going to be dysregulation someplace in the front as a first guess.
What do you think, Santiago?
Yeah.
I would probably say, if I remember correctly, I think Jay at one point showed us an EEG of a bipolar client. I think there was heavy beta spindling involved. So, I mean, I wouldn't be surprised if that were the case. Again, exercising caution because beta spindling is non-specific. But I would not be surprised if the right insula was to be involved somehow as well, with explosiveness and the sudden abrupt mood swings. And again, if I think the client wants it to be called bipolar or depressive or something so they can make sense of it, I try to stay away from labels as much as possible. And I just, again, go to, this is a brainwave pattern. It causes you to react this way. Does it coincide with what you've been experiencing? And they go either yes or no, and if we're reading things correctly, they're going to go, yeah, that's me, that defines me. If the client happens to be there with a significant other, well, the significant other can also confirm on what we are assessing based on that brainwave pattern. But I would go with what Laura's saying, the ACC, the anterior cingulate cortex, the limbic system, and probably the right insula, which is more of a presentation that would fit the classical behavioral patterns that you normally study in the bipolar.
All right, guys, we'll put that one to rest. We gave the listener about half of our show. We love our listeners here at NeuroNoodle. Santiago, you share a passion that I have. Concussions. Now that we're getting out of COVID and we're getting our vaccinations, or hopefully we are, kids are getting more active out there. Don't you think if a kid is going to play sports and they get a physical, shouldn't they get a mental physical by getting an EEG to get a baseline in case something happens during the season? What's your thoughts on that, Santiago?
Oh, absolutely. I couldn't agree more with you. Every client that I see, regardless of what they work with me for, it's something clinical or it's peak performance related, I always go with an EEG. And as a matter of fact, I think every human being on this planet, one way or the other, whether they want to work in something or not, they would benefit from getting an EEG. To me, EEG and QEEG are very powerful, underutilized tools, and we can obtain so much information and it can come handy at any time. And like you say, if an athlete were to get COVID, if they were to get a concussion, if it's something happens to them that's altering their behavior, we have that baseline to go with. And if we reassess, we have a comparison point. I've been lucky enough to be able to see, unfortunately lucky to see some pre-COVID EEGs, post-COVID EEGs. And it's good because it helps us provide tangible evidence of the effects of the virus on the brain. The same applies to any athlete from any age, because there's a gazillion things that could happen during the season. Injuries, TBIs, concussions, sleep issues. I mean, you name it. So I think the EEG is a must.
What do you think the future of sports looks like? Because right now, look, I'm not the professional here, but it seems to me that the concussion protocols that are being used right now, they seem a bit antiquated, or maybe they're not. Can you correct me? What do you think the future looks like to determine if a kid or a player should get on the field? When would the EEG come into play with that?
I would hope that doctors and fans and coaches and athletes embrace what we can do with neuroscience and the amazing tools we have at hand. Just to be very specific, look at how long it took the NFL to finally admit on CT, and how they try to hide it for so long, and all the havoc it wreaked on so many people. Obviously, CT is not something that you can pick up. As far as I understand, you can only pick it up with an autopsy. It's not something that MRI or an EEG will pick up. But as the technology gets better, I would hope that standard practice, not only for elite sports, amateur sports, or any type of sporting event, or for any type of athlete, to get assessed with these technological options. And that way we can not only have better assessments, but we can come up with better ways of intervening, not only to enhance performance. We're talking about people here. And if there's anything I've learned about elite sports, is that they're not healthy. They're anything but. Elite athletes, we think of them as very healthy people, but the practice of elite sports or any kind of elite performance, musicians and actors and you name it, it's not really healthy. It's a very hazardous occupation. So to me, doing an EEG, doing an MRI, doing more advanced QEEG should be standard practice. It should be as mandatory as getting vaccinated for smallpox, or as mandatory as getting vaccinated for any other kind of condition. It should not be a discussion of whether it needs to be done. It should be done.
Doc, what do you think?
I had a comment and then a quick question for Santiago, but the military has, some access to devices, certainly the development of them for kind of battlefield TBI analysis. So it's out there, Pete, and it's not just, the sideline doc saying, hey, what's your name and what week is it? What day is it? So that it's out there. How and when that translates into the sideline of a high school football or soccer game, you know what I mean? Hard to say, but there are some things that are getting more into how we look at brain function, and that's EEG. And so as everything shrinks and becomes more accessible, I think it's probably coming. But the question I had for you, Santiago, is we are focused on neurofeedback and neuropsych, but we tend to see folks that aren't doing so well. And I know that you work with elite athletes and around the idea of peak performance. Can you talk to us and our audience about just how that is a little different, and maybe it's not, with treating people with dysfunction?
Well, athletes are different in that in many ways they're built different from the average person. Their central nervous system and their organisms in many ways are more sophisticated. But that comes with a challenge too, because the more sophisticated the organism, the more challenges you're going to face. Now, as far as peak performance goes, I find it somewhat easier to work with them in that they're very motivated individuals, and they're often very accessible to working with you. If they believe that what you have to offer, it's going to take them to the next level, they're really open to the idea. If you tell an athlete to jump out of a building and go head first, feet first, what do you want me to do? If you tell a clinical client, I want you to jump out of the building, they're going to question you more, and you're going to find more resistance and they're going to be more hesitant about it. Now, on the other hand, because athletes are so sophisticated, it's also a challenge to work with them sometimes. As far as the patterns go, I don't see the clinical population and the athletes being really dissimilar. In my first week in my internship in sports psychology, I had a figure skater who attempted suicide. Suicide ideation, depression, sleep disturbances are quite common in athletes. I think that the way you handle it is somewhat different, but I see some of the same underlying issues. And again, in some ways, when you are talking about performance, they're more motivated than the average Joe, but they're more challenging in some other aspects. A lot of them, especially in Latin America, are very religious or really superstitious, and that's hard to get around. It's very hard to get around really engraved and sustained religious beliefs or superstitions. And I don't think there's any amount of neurofeedback you can do if there's not enough flexibility on behalf of the athlete. The other issue you have to contend with sometimes the coach. Coach wants one thing, the athlete wants a different one. And coaches tend to be really territorial, especially when it comes to sports psychology. There is a belief that the psychologist is there to manipulate the athlete, and then you're going to gang up against the coach with the athlete. So that can be somewhat of a challenge. And I think in elite sports, the first person who should benefit from an assessment and intervention is the coach themselves. And there's not a lot of focus on it. I was watching a documentary the other day on the English Premier Football League, soccer in the United States, and they were discussing depression among athletes and suicidal ideation, and they find it's quite high. These are elite football soccer players, and the rates of suicide ideation and sometimes suicide among coaches and players is really high. And there's more expectation from athletes. There's obviously more pressure from them. So in that way, they're not different from any of us. It's just like a doctor or an accountant. They feel pressure at their work. Athletes sometimes more because they're in the public eye. So to me, there's differences, but there's similarities as well. And I think the approach should be the same. It should be holistic. It should be integrative. And having the tools, it should be mandatory for them to go through the process.
So what exactly are you targeting, and what methods do you use? Are you using like full cap training? Are you doing single channel? Are you raising gamma? Kind of what's your approach?
Well, I normally do an EEG, a QEEG, and I first of all see what was not looking right. So some clients have ADD, ADHD patterns in which they have a lot of theta at the vertex. Something I commonly observe is sleep disturbances among athletes. That's really common. You're sharp vertex wave with the eyes closed, or not making a lot of alpha in the back of the brain when they close their eyes, or maybe jumping into stage 2 sleep too early. So I do a lot of work for sleep disturbances. And with the eyes open, I look at what's not right. And again, I haven't seen very dissimilar patterns in that they're athletes with, the beta pattern at CZ, which is a marker for peak performance, but it's a marker for insomnia. If I see new rhythm, I normally don't touch it, because usually in an athlete, it means talent. It means the capacity to positively dissociate. As far as peak performance goes, I use a lot of CZ training SMR. There's one protocol that I particularly like, which is FP1 with the eyes closed. That's not something that's quite commonly used, but I find that it helps a lot with relaxation. It helps a lot with emotional control. I find that I can easily access the amygdala from here, just in a different way that you would do from the temporal lobes. And with that protocol, I've seen enhancements in sleep. I've seen enhancements in behavioral inhibition. Something the athletes really report is I can control my emotions more efficiently. I'm not as reactive as I used to be. I'm sleeping so much better. And some percentage of them also report feeling or having the ability to visualize better. So if they want to visualize themselves in competition, it kind of enhances the visual experience of doing that.
So let me ask you this. I was interested in how you were phrasing things about the elite athletes are unique from your average clinical population. So I have all sorts of questions around that. But the first one is about the usefulness of the QEEG. Are you comparing apples to apples? if you have an elite athlete, is it correct, or is it, misleading to compare your elite brain to an average brain? Like, are you seeing more dysregulation that might be false?
Not necessarily. Again, what I really see a lot of is the sleep disturbance patterns. So closing their eyes and the alpha is it's not occipitally, or going into a lot, quite a few athletes fall asleep when they do the eyes closed. Within the first 30 seconds, they're out, and you start seeing they're jumping to stage 2, or they have a vertex wave, and you immediately know something's not right. And it's not that uncommon. I think it has to do with the fact that they're traveling all the time. They're, throughout different time zones, and, their circadian rhythms get out of whack. As far as the eyes open go, the one characteristic I notice the most is that they do tend to have a little bit more alpha at PC. Their peak alpha frequency sometimes tends to be higher, and I think that's a facilitator for their peak performance days. They tend to have more beta rhythmicity over the vertex as well, and a lot of them make more mu than the average person.
Yeah, talk about that a little bit more. I was interested in how you said that, the positively dissociate. Can you explain that a little bit to people who don't quite understand that?
Well, the mu rhythm, as it happens in the vertex, usually can be associated with, a performance enhancement component, but it can also be a performance hindrance. In people who have mu hindrance, usually means that they don't have an ability to sit still. So it would correlate with hyperactivity in ADHD. It would correlate with a dysregulation of the mirror neuron system, something you would see in people in the spectrum disorder, autistic spectrum, with not being too sociable, not being able to connect emotionally. I've seen it in trauma, for instance. A lot of the trauma clients that I work with present mu, and to me, that's a form of dissociation. And dissociation, as in, I want to get away from the emotional pain, I want to get away from the psychological pain. However, in athletes, when I meet a positive dissociation, is the ability to access what we normally call the zone. So these are athletes who, in spite of experiencing critical moments during competition, they can isolate themselves and they can flow through the motions. So there's a lot of pressure, the stakes are high, and yet they can perform. So they get into a zone, they go into this bubble where nothing bothers them. And for most athletes, I find that mu, it's really performance enhancing. So I stay away from the vertex, I stay away from the sensory motor strip, and I don't touch it at all, because unless I see evidence, behavioral or otherwise, that's hindering their performance, then I try to address it. So I normally would train, the occipital cortex, or maybe CZ, which is, or frontally something, to not mess with the mu, not to alter it.
Right. So mu rhythm, just again, for the average person, we have, potential patients listening, and moms and maybe other athletes listening. So we're talking about a specific brain rhythm, a specific pattern called the mu rhythm. And it's a high amplitude, high alpha. How would you explain it, Santiago?
It's one of the alpha generators, and it's in the alpha range. I normally see between 10 and 11, 10 and 12 hertz. It can be slower, but normally it's in that rhythmicity. Right. And it's got a wicked pattern, yeah. Yeah,
and you're going to see it kind of over the sensory motor strip. And so in terms of what the brain's doing, it's being able to predict what you're going to do before you do it. Is that kind of how you would say the role of the mu rhythm?
I would say it's more a way to isolate yourself from something. And again, in athletes, is I can flow in spite of the pressure. So I can get into a bubble, and I know there's pressure around. I know that the spectators are yelling. I know my opponents are trying to distract me, and then yet nothing gets to me. In somebody who's undergone trauma or PTSD, for a war veteran, it's a way of going into their own inner world, so they don't have to experience the agony of the flashbacks or the physical pain they might have residuals from that trauma.
So the disconnection of your
right.
Limbic system from what you're doing or from the environment.
Yeah, it's a way of disconnecting, getting out of your own way, if you will. And I think it favors that process. You know, in trauma, you want to break that cycle because you don't want to go into dissociation all the time. Otherwise, it prevents you from being effective. But if as a peak performer, you have and you have the capability to tap into that, it's going to be quite beneficial because no matter what's happening, you know, you can go through it. And athletes report that it feels like a dream, you know, and they report like they're in a movie and they're sitting in the stands and the screen it's playing what's happening in front of them. And yet they go through the motions without feeling, you know, any pain or any agony or any anxiety. So either ways, it is a distraction. Sometimes it's a distraction that hinders your health. In other ways, it's a way of getting out of your own way, of your own skin, kind of an out-of-body experience that enhances your ability to do things well. And I have not only seen it in athletes, I've seen it in police officers, elite police officers, fighter pilots, surgeons, you know, people who really have to focus on dangerous tasks for long periods of time. And when they tap into the neo, they just have the sensation of flow state where everything's going their way. And I find it quite fascinating.
Yeah. And so it sounds like you do a lot of single channel training. You don't necessarily do cap training.
No, I never done cap training. I usually do bipolar montages, two electrodes, you know, one active, the other one references. It's what's worked for me before. You know, I've experimented with 3-4 channels somewhat, but I usually stay with what in my experience has worked for me. I know there's a lot of people who do Z-score training full cap. You know, I've never tried it.
Yeah, and again, and this is, you know, too far down the rabbit hole, especially for, you know, I can hear Pete thinking right now, but you know, again, we're talking statistics when you're doing Z-scores, and we're even talking statistics when you're doing the Q. So again, you're comparing people who are very elite who might, you know, be normal for them, but abnormal for the, you know, average person. And so, right. You know, I always feel like I'm comparing apples to oranges when I do too much Z-score training or, you know, think about the QEEGs too seriously.
Right. And I always compare the client to the client. You know, if
right,
it is
exactly.
an athlete, I compare them to themselves. You know, if I were working with, you know, Michael Jordan, or Michael Phelps, or an Alex Honnold, I compare them to themselves. Because, you know, there's no two people whose brains are wired the same way. So to me, there is no purpose. It would defeat the purpose if I try to compare Michael Jordan's brain to anybody else's, because it's his brain, that's how it's wired.
Yeah, hey, let me throw, and I know sounds like Skip has a question also, and I'm sorry, I'm kind of monopolizing this today, but I'm a musician. Pete is actually a musician, and I hang out with musicians. And I have my guitar teacher donated his brain to us in the way of a QEEG pattern, okay? So this might be too science fiction-y, but you know, so the normative database for the Qs, like Thatcher got a group of people considered, quote, normal, according to DSM, I guess. But he's got his normal brains. And so when you do CAP training, you train people toward that normative database, okay? So Dave, my teacher, he donated his brain in the form of, you know, the data. And Lori Counts is another guitar player who is a genius guitarist. So what I was wondering, and what you think about this, what if we got a normative database of superior musicians and we had students who want to become better musicians? Do you think it's feasible to train people toward our guitar genius database? What do you think about that?
I think it's rather interesting and would be quite useful. You know, as a matter of fact, it is Jay who told me that the Australians are actually developing a database for athletes. So we're going to have an EEG database.
People are doing it, yeah.
Yeah, and I think musicians is no exception. It's not going to be the same, but it gives you a point of reference to aim for. And I actually think would be quite useful. You know, we have a database for musicians and one for athletes, and within sports, one for specific sports. You know, just like the Koreans did, they're now differentiating men from women. And that's exactly what we need to do. And it's fascinating work. And, you know, our field is only scratching the surface, and, you know, the possibilities are endless. I don't see why not. You know, same for students, same for CEOs, same for neuropsychologists. You know, we're different, but we're similar in many ways. And if you have a brainwave pattern in musicians that you want to get to, well, you can train that person to get as close you can to it. But at the same time, you're enhancing their own talents and their own skills and harnessing into that ability.
Okay, thank you for giving me permission to do that, because that's my next step. Okay, I'm going to be quiet. Skip had a question.
It's all good, Laura. It's all great stuff. I had a question before the question that I posted, and it was around visualization. You mentioned it with the athletes, and you know, I think we understand what that entails. And there's all kinds of great research out there about the effectiveness of visualization standing next to, not literally, the physical performance, meaning folks can do visualization on some kind of skill and develop proficiency at it at the same rate or better than the physical practice of it. There's a study on folks doing free shots in basketball, free throws. And so with just that in mind, this visualization idea, in my clinical work, we work or discuss or practice visualization with folks that aren't, you know, premier athletes. They're just trying to have a better life. And so we're like, all right, well, what does that look like? And then you kind of flesh it out so that we can add then an emotional component to it, and they can practice, you know, visualizing what this life would be like. The idea being that they're developing the neural substrates or the neural connections to having that reality, and then the reactions to it, and the idea being that affects the development of that happening. Anyway, all that said, what's it look like on a cue when you're looking at, you know, and I'm throwing a wide net here at you, Santiago, but what's that look like when you're seeing visualization? Like, how do you know if someone's good at it? How do you know if they're not? How do you train up to it?
Well, it's a good question. And the first thing that is important to understand is that not all athletes have the ability to visualize or see the images in their head. Now, in my experience, in my anecdotal experience, what I've noticed is that when there's an eye closure and there's an increase of the alpha response, those athletes who make, you know, higher amplitude alpha brain waves, normally about 9.5 hertz, tend to be better at producing the images, or at least that's what they report. You know, they report more clear, crisp images, and they can actually hear the sounds. And sometimes they report feeling the smell, you know, smell of the pitch, smell of the grass, smell of the, you know, sweat of the opponents. And that's been my experience. I know that, I think it is Paul Swingle who has also mentioned that. And, you know, Paul Swingle created an assessment called clinical cue. Now I think they call it the quick cue or the clinical cue. I don't remember what exactly they call it today. And one of the points that he assesses is O2. And he talks about when a client closes their eyes and alpha increases in the back of the head 300% or more, usually that's a marker for talent. So it's a marker for peak performance. I don't know if he's published it or it's more of his anecdotal findings, but I find that interesting. And it coincides with what I've observed. You know, I see a client whose peak performance, they close their eyes and the alpha goes really high and it's very nice, you know, sinusoidal. When we do some visualization and mental imagery exercises, they report that they can do better. Now, do I train that with all athletes? I don't, you know, because just like mindfulness or meditation is not for everybody. So what I try to find is I try to correlate what the brainwave pattern of that athlete facilitates in other skills. So, you know, the alpha in the back for visualizing, I teach mental imagery to that athlete. If they don't, then I don't work on it, because I know it's going to be a waste of time. It's going to be a frustrating experience for the athlete. A lot of sports psychologists tend to do a one-size-fits-all approach. And, in my early years, I would make the same mistake. I would work with a team, basketball team, and I would have them laid down, and I developed this script for mental imagery. And I would ask them, and half would say that was great. The other half would say that's just a waste of time because I couldn't see anything. And when I came across neurofeedback and the EEG, it helped me understand how different we are and how using the neuroscience can help us understand the skills and the talents that are specific to each person. So even I may be working with a team, I'm not going to work with the team together every time. I'm going to take the athletes with a specific skill, and I'm going to train that brainwave pattern to optimize it. And I'm going to take the athletes with a different brainwave pattern that helps them with a different skill, and then I'm going to train it. And then I put those groups together, and we have a team that's going to perform better. That's sort of the approach that I use, because I think that training the same protocol with all of the athletes, it just doesn't work. And if you look at their EEGs, it's not going to work, because every athlete is different, every person is different.
Yeah, makes a lot of sense, right? We don't treat everybody that walks in that says ADHD the same by ever, right? Okay, thank you.
Yeah, it's as if we take every ADD client and we put a sensor here at CZ and we do theta beta ratio or the theta SMR ratio. And we might be wasting our time because their ADD might be frontal slowing, or it might be, a lot of frontal beta, fast activity, and they're more anxious, or, it's something coming from the posterior cortex. So, that's why we assess, because even though they have the label, even though they've been diagnosed as such, the brains are going to tell a different story.
Right.
Doc Santiago, we're getting towards the end of the show, but I want to throw out one more question. It's election season here in the States for school board. We just had ours the other day. And when the candidates go up and they speak why they should vote for them, you don't hear anybody talking about special needs kids and the budgets that are going to have to increase. Seaburn Fisher was on the show a few episodes back and said that schools are going to be underfunded by 80% in dealing with special ed kids. I was just wondering if the docs or Santiago had any thoughts about what they're going to see when the kids start returning back to school. I don't know what it's like in Singapore or South America, but what should the school boards be prepared for to get a heads up once kids come back to school, mental health wise?
That's a really good question. I believe that not only for kids at school, but for human beings in general, we're going to see the consequences of what happened in the next years. I think that what we're seeing now, it's only the beginning, and we haven't seen it all. And I think as far as mental health goes, we're going to see an increase in anxiety, in depression, and physically we're going to see the consequences of this. Zoom fatigue, doing everything virtually, not being able to read and write the way we learned, is gonna create a lot of issues. I would not be surprised if I see kids with very tired brains. And when I say very tired brains, I'm gonna see, they're gonna be dominated by very slow alpha. They're gonna be dominated by theta frequencies. They're gonna be dominated by delta frequencies. For a lot of them, I think their beta, their SMR, even the gamma, that helps that nesting and the coupling and the processing of information is just going to be gone. We've all been exposed to the light and technology for far too long. I believe that we're going to be dealing with kids who are going to have problems socializing personally, because the socializing, it's been happening on a computer, on a laptop, on a cell phone. Just like you see the kids today, because pornography is so accessible through the internet or your cell phone, Teenagers today and young adults, when they are about to have their first sexual relationship, they're having problems because they have access to porn. That's how they learn about sex. So when it comes, when it's time to with the opposite sex, especially for males, there's a lot of issues. Premature ejaculation and problems achieving an erection. If we transport it to social interactions, I think kids are going to have hard times interacting in person without a mask, and trusting that others are not out there to harm me or infect me with some kind of virus is going to be crucial. I definitely see depression. I definitely see trauma-related behaviors or trauma-related conditions. Dissociation. We're going to see hypervigilance. We're going to see a lot of mistrust in others. And I think it's going to be based on the fact that people are going to have very tired brains. And schools need to be prepared for that. And again, in general, in Singapore particularly, everything is working quite well. I mean, the pandemic is very well controlled here. Cases are at 0. So schools are functioning normally. Kids are going there. Universities are open. But there's a lot of pressure to perform. And what I'm noticing is that there are, teenagers and young adults who report feeling desperate because they don't know what to do with the rest of their lives. So there's a huge expectation from adults in people who are 19, 20, 21 years of age to have their lives figured out. And I tell them, you're only 21. I'm 44 and I don't know what to do with my life. At 21, you don't have to worry about this. But, there's a lot of pressure because you need to go to good school. You need to get good grades. You need to find a good job. And then you need to get a good salary and just, be in the rat race for the rest of your life. If we combine that with being under lockdown for some time, I think we have the perfect ingredients for, and it's going to be disastrous unless we really do something about it. And going back to the question, this is when the tools we have can be very useful.
I had an insight yesterday from a 14-year-old girl yesterday about the Zoom school. Something I didn't think about. I mean, certainly all the fatigue that you mentioned, Santiago, and the socialization, and you gave a male perspective. From the female perspective, she said being on Zoom, even with her friends, not even in school necessarily, being on Zoom, even with her friends, makes her anxious. And I said, why? Tell me about that. And she said, because when she's doing Zoom, she's not looking at her friends, she's looking at herself. So it's like, yeah, right? So she's looking at herself and she's picking out all her flaws, and she's, basically you're trying to have a conversation with somebody else while you're looking in the mirror, and you're at this stage where, yeah, it's all, your identity and you're trying to understand your role in life and who are you, and comparing yourself to, the rest of your peers and this stuff. And she said she spends the entire time, even in school, just staring at herself. And that just brings up all sorts of anxiety and just think about the development of yourself. If you're referencing yourself rather than kind of, being able to learn from other people and other social cues and things like that. So I thought that was a very interesting contribution to my understanding of, what's happening to these kids when they're trying to learn through a computer screen.
On that same note, maybe just from a different direction, we've been doing our neuropsych assessments via Zoom since last May, right? So coming up on a year, geez. And in all that time, no kidding, other than folks just being used to it and it's the way it is, the only folks that said they enjoyed it or preferred it were folks with social anxiety. And so it almost supports, not trying to get too pejorative about it, but you're following me that it works for them because it allows them to kind of maintain that distance, and everybody else is just going along with it because it's the way it is, right? So there's another perpetuation maybe of things that aren't okay or helpful. How about that?
So we're gonna need more counselors in the schools. I mean, the testing. That's what all the psych literature is telling me. The APA monitor every month is like, hey, how do we stay ahead of this thing?
And that's the theme. There's answers, but not super clear ones. It's like, hey, we got a tsunami coming.
Yep.
So from the budgetary standpoint, the ratio for the time being, you're going to need more counselors per student. Is that what you guys think?
Open your wallets.
Yeah.
Well, you have people that are fiscally, conservative, responsible, and they hear that, and we're trying to set them up. Hey, prepare. I just haven't heard anybody talk about it. Then all of a sudden we're going to need it, and there's no money. So unless the federal government steps in, we might be hard pressed. That's all. It's just something I haven't heard anybody talk about.
Well, yeah. And then, so, talk about the consequences. We talk about moo rhythm and being disconnected and dissociated. I mean, I'm not trying to predict negative things, but on the, hopefully everything works out fine and people adapt and they step up, because that's who we are as people, is we find a way and we go positive. On the negative side of things, if, the people who cannot do that, cannot adapt, you're going to have a population of kids, teenagers, young adults who are disconnected, right? If they have no, connection to the environment and they're living in a virtual world. Yeah, we're living in a computer game. What does that mean? They're going to be immune and disconnected from people, and hopefully, I don't know how many bad things can happen from that, but it sounds like there's a good potential.
I like your enthusiasm though, Pete, because preventative measures have always been hard to fund politically. Right? It's like, hey, let's get together and pay for this thing that's going to show up 5 years from now, and whoever you're talking to is going to be out of office. But it's real. It's real, right?
Yeah.
Yeah.
Well, I mean, it's two things. We got to get budgets for this, and we got to have the dang insurance companies pay up. We don't have enough time to get in insurance companies, but we're at the end of the show, guys. Santiago, what's the best way for our listeners to find out more about you? Heck, how can we find more about you besides Jay Gunkelman?
Well, you can follow my Instagram, which is Santiago, and then my YouTube channel, Santiago Brand, just like you see on the screen. That's the best two ways to find more about my work, and try to be somewhat active on Instagram and post videos on YouTube whenever I have a chance. So if you go to my YouTube video, there's videos in Spanish and in English about my work, workshops, interviews, some of what I do.
Oh, Santiago, we're going to bring you back. Yeah, this is a good show. Could you recommend somebody else to bring on the show?
Oh yeah, definitely. I'm going to say Linda Walker. If you already didn't have her, hands down, she's one of the greatest in the field. Very close friend of mine, my business partner at SciTech Bioscience, and she's very knowledgeable as well. She worked with Jay on Maggie for the documentary, and she's done a ton of work with troubled youth. So I think that she's a really good fit for the show.
Oh, that's outstanding. We're gonna reach out. We're gonna reach out. Thank you, Santiago.
Quite welcome.
Santiago, great show. Thank you for coming on.
Thank you for having me. I had a ton of fun. And thanks to Jay for suggesting me. I gotta be honest, when I read that, I was reading through Facebook and I said Jay recommends Santiago Brand. I couldn't believe it. I was just really ecstatic, and I couldn't sleep that night because I don't know why he did it, but he likes me for some reason. So I had a good time. Thank you guys, and I hope we can do it soon.
Thank you, Santiago.
And it's past 10 o'clock now. You'll have no problems going to sleep after the show.
Hope so.
All right. Dr. Laura can be found at Jansons.com. Dr. Skip can be found at drskiprin.com. That's drskipHRIN.com. If you have an idea for a topic or a guest, please email me, Pete, at NeuroNoodle.com. Please give us 5 stars on Apple Podcasts. It really helps get the word out on neurofeedback. The more that listen, the more that we can help. Smash that like button on Facebook, Instagram, and follow us on Twitter. Cue the non-copyrighted music. Santiago, thank you. What a great show.
Yeah,
thank you, guys. Thanks for having me. Had a good time.
Appreciate it.
We're going to reach out to Linda. You go get some sleep now. You look tired.
Yeah, I will. It's been a long day.
All right, guys.
All right, guys. Have a good day.
Bye.